Alright, so, this is basically, kind of piggybacks on what the presentation we did for all the nursing staff. So, kind of the background behind this is we're trying to institute, the ABCDF, bundle in the ICU, which is basically a bundle of measures to decrease pain, sedation, analgesia issues, delirium, and get folks off the vent faster, okay? And that's kind of the background behind all this. And so we've already went over this with nursing, to try to build a culture of, hey, let's wake up the patients in the morning every day, which is not something that's typically was done in the past, and hopefully be able to coincide and collaborate with respiratory therapy to do some vent weaning in association with them being waking up basically in the mornings. That's the whole idea behind this. And I'm going to kind of lay out the protocol and see if you guys have any questions, and hopefully get everybody just familiar with the idea. So that's ABCDF bundle, what we talked about. And today we're going to kind of focus on the B. So I'll go through all the letters and what they mean, just so you guys kind of understand the big picture. But really, for respiratory therapy, it's going to be the B portion of the A to F bundle, okay? So this going back to this A to F bundle, this came out, it's kind of been evolving over the last 15, 20 years. But in 2018, which was the most recent guidelines for the prevention of pain, agitation, sedation, delirium, and sleep disruption in the ICU, they came out with this A to F bundle that kind of basically accomplishes each measure in those clinical guidelines. And the A stands for assessment, prevention, and management of pain. So the whole idea is, if you got people in the ICU, treat their pain adequately, because a lot of times if you treat their pain adequately, you don't have to use so much sedation, okay? B is the SAT, which is sedation awakening trial, and spontaneous breathing trial. So both SAT and SBT, that's why it's B, both of those things. C is choice of sedation and analgesia, and what that means, just kind of quickly, is we try to use less benzodiazepines, so we try to avoid like the Versed drips and things like that. Try to use propofol, which is shorter acting, cut it off and they wake up quicker, or Precedex, which that's basically what we do already. D is delirium assessment, prevention and management. E is early mobility, so that getting PT and OT and getting the nursing staff involved and getting folks moving quicker. And then F is family engagement and empowerment. So having families available and participate in rounding so that they know what's going on, and so that hopefully they can actually even help with the care. So that would be the idea there. So that's what the A to F bundle stands for. So it takes so many people, all right? So it takes the nurses, it takes the patient care techs, you all, pharmacists, the therapists, and then the docs. So it takes us all, we all have to work together to do this, or it's not gonna work. And obviously you can see where the limitations would lie, as folks aren't communicating well. But specifically today, we'll focus on like respiratory therapy role in the spontaneous breathing trial specifically. Which one do you think each of us are? Maybe the pulmonologist? Do we have like a Markham or a Jaggers or a Basha? Basha might be, I don't know, one of the riders.
Yeah.
All right. So SAT. So what that is, that's the sedation vacation. All right. It's first thing in the morning, 7 a.m. is the plan that we've talked about. Used to they do it on night shift. I think they still do it on night shift. But the whole goal is to get the day shift nurse to come in and on their initial assessment of the patient, pause their sedation and see what they can do, okay? So that's what SAT is, so to see if they still need their sedation. So SBT is, and you all know this, it's basically where you're putting them on minimal support and seeing what they can do, okay? See if they still need to be on the ventilator or not. And there's been studies looking at coordinating the two, which would make sense in that actually improving the likelihood of extubation. So it only makes sense if you wake the patient up and then put them on a breathing trial, that it works better than them having been woke up at 4 a.m. and now they're not awake, but then you decide to do a weaning trial, oh, we need to hold, it's just coordinating the two is the only way it makes any sense, right? Okay. So that's our whole goal, coordinate the two. Okay, so both of these things, SATs and SPTs, they determine the patient's needs, whether it's sedation or for the vent, okay? Both rely on the patient's spontaneous trial. So you actually, by pausing their sedation and letting them breathe, you see what they can do. The interesting thing, and I pointed this out in the lecture of the nurses, is both of these are often more reliable than the clinical judgment alone. So I can't always predict who's gonna do well, okay? And just like you all, I mean, you got this sense, I'm sure you've seen a patient on the ventilator, you know who might do well and who won't. But how many times have you kind of been surprised? It's like, oh gosh, I didn't think they do well, and then we actually let them breathe. They do better than you think they can. And then there's some that you think they do great, and you put them on a breathing trial, and they're just not ready. So you gotta look and see before you even know. But again, it requires everyone work together to get it done like it should. Okay, why would we do this? Well, it's safe. So in the old days, people were afraid, oh gosh, if we wake them up, they might self-extubate. Okay, if we pause their sedation, they might no, that it done in a controlled environment, when somebody's watching them, you're really not gonna have any more complications than you do otherwise. In fact, you might have more if you're not doing these, because people are sedated for longer, they develop ICU-acquired weakness and delirium, they're on the vent longer, all of those sorts of things. So the safe thing is actually to wake them up and see what they can do in hopes to get them off the ventilator as soon as possible, if that's possible. So that's where you get improved clinical outcomes. So reduced ventilator-associated events, decreased time on the vent, and reduced ICU and hospital length of stay, which is huge from an organization standpoint. I put a QR code if anybody wants to take a picture. I haven't checked this out and see if it works. So I kind of want to do this. So. Perfect. It works. Perfect.
Did it work? Yeah.
It does. So that's something you might want to save in your photos or something. But that's the flow sheet. Oh, I should actually show you in a second. It's going to look like that and that. But you'll have it on your person here. But basically what this goes through it is the sedation awakening trial and the sedation or spontaneous breathing trial flow sheet. And this is the part where you all and the nurses at the bedside are going to be the ones to screen these folks and determine if they're ready, because the docs are not going to be at the bedside continuously. You guys would do this on your morning rounds. Because, correct me if I'm wrong, there's always someone assigned to each ICU, right? Or at least one of the ICUs. And you all come in the morning whenever you get here and start making your rounds on all the patients, right? Mm-hmm. And so the whole idea would be for folks on the ventilator to get with that patient's nurse and see, hey, because it may be that, yeah, they're starting in room 1, but they also have a patient in room 3 and 7 too. It's like, all right, in room 1, the nurse is going to start and wake them up and say, hey, I'd like to do a breathing trial too if that patient does well with their awakening trial. Okay, that's how you just work together. And if the nurse says, hey, it's going to be probably 8:30 before I get to room 5, just hold off. I know that's where it just takes a little bit of coordination. I know that's hard to do, but it's the right thing for the patient. So that's going to require a little bit of work, okay? But the whole idea here is to do their screen, so the nurses do this part, the sedation awakening trial. So they're not even gonna cut the sedation off unless they meet these things. So, and they're all, it's not rocket science, right? If they're actively seizing, if they're in status epilepticus, they're not gonna you're not gonna turn the propofol on. The same thing goes if they're having active alcohol withdrawal, they're in delirium tremens, we're not gonna do this. They're agitated already, they're paralyzed already, we're not gonna do this. They're having an acute MI, they've just come in with a STEMI or an NSTEMI and they're still being managed for that. We're not gonna do it, they've already had their stress test, right? You're not gonna see if they can breathe too. But normal intracranial pressure, that doesn't really pertain to our facility, but that is one of them. And then, so let's say they pass the safety screen and the nurse pauses their sedation. If they get anxious, agitated, you just know it when you see it, then they failed. They start them back on sedation. Or if they're breathing more than 35 times a minute, that's not somebody that you want to keep in that condition. If they're dropping their SATs, if they're respiratory distress, they're belly breathing and dysynchronous with the ventilator, or if they go into cardiac arrhythmia, those are SAT failures. If that happens, the nurse is going to restart sedation at half of the previous dose and then titrate accordingly to get that back under control. So does that make sense? That's what the nurse is doing behind the scenes. So where you guys come into it is, and that's just what we talked about right there. SAT screen, SAT failure. If they fail, you go back up to the top and you try again tomorrow, okay? So let's say they pass the sedation awakening trial. This is where you all come into play. So they've done well, they're doing great with sedation off. Well, let's see if they can breathe. So then you do the spontaneous breathing trial. And here's your safety screen on that. It's basically all the same things as above. They're not agitated, their SATs are good. FiO2 50% or less, so you're not gonna do this on somebody who's on 60-65%. PEEP's gotta be less than or equal to 7.5, so most of our folks are gonna be on 5. You're not gonna do it if somebody's on PEEP of 10 still. No myocardial ischemia, they're not on pressors, and they gotta be spontaneously breathing, right? They're able to trigger breath, okay? So if they do that, then you put them on a spontaneous breathing trial. Okay, and we'll get to the specifics of what is the trial, what is the settings, but let's go through this flow sheet here. So what is a failure? So they're breathing more than 35 times a minute for 5 or more minutes, or they're not breathing, they're less than 8 times a minute. Okay, your apnea alarm's going off. You all know all this is not, it's very intuitive, okay? Oxygen saturation's dropping, they're in respiratory distress, mental status is changing, they're becoming confused, or they go into an abnormal heart rhythm. It's just those things. And y'all called me a million times and said, hey, SATs are dropping, they're breathing 40 times a minute, you mind if I put them back on? So, of course, and so in this situation, you just do it. You just say, hey, I had to put them back on, they failed. You don't have to call and let them suffer until you hear back from us. It's like you just document they failed. Okay, if they pass that, well then you consider extubation. And this is where you have to communicate with the doc and say, hey, listen, they're on pressure support 8, peak 5, 30%, they're doing great. What do you want to do? Because there may be other circumstances, like, oh, well, we would extubate, but cardiologist is planning to take them to the cath lab this afternoon, or they're having dialysis at noon. Do you maybe want to wait till after dialysis? There's always those situations where you don't just pull it, but you have to coordinate with the physician, but at least communicate that they did well. Okay. Does that make sense? Any questions about that so far? The screen? And so the whole goal is to have this little chart, and we can make another QR code, but just have it available and you can look at if there's any question. But most of this is it's not real complicated. It's pretty simple, right?
Yeah.
Okay,
Can I say
Even for
something?
me.
yeah,
So when we first started this nursing wise,
yeah,
several of the nurses asked, cause they can see the breathing trial criteria too. They were like, my patient's on a pressor, what do we do? The patient was stable, they were weaning them off, they were on a very, very low dose, and so I was like, just call Dr. Rutledge.
Yeah.
They were like, really? I'm like, don't not do this.
yeah, they're
I'm like,
guidelines, it's
Yeah.
not hard and fast rules, so.
I was like,
it's
just call Dr.
yeah.
Rutledge, he may say go ahead and do it anyway.
Yeah. Yeah, if
So-
somebody's on 0.03 in norepinephrine, they're about to turn it off, it's different than they're on like 20 mics and a little marginal, okay? They're still unstable versus they're really pretty stable. And they're actually would probably be even better if they were off their sedation.
Yeah.
Right. So that's what that is, and that's kind of the flow sheet, what we ought to think about. And if they fail, you put them back on their previous vent settings and we try again tomorrow. Okay, you don't try again today, it's like you do it once, if they fail, sorry, you do it again tomorrow. Okay. All right, so what is the spontaneous breathing trial? So this, and I kind of did a quick literature search to see, if there's anything that's come out on what is considered a spontaneous breathing trial, and there is a lot of kind of heterogeneity amongst ICUs. And if you look in the guidelines, it just says a spontaneous breathing trial and it mentions pressure support, okay? But as far as specifics, there is not a hard and fast rule. It does recommend pressure support over T-piece trial, okay? So that's good, right? But as far as the numbers, the specifics, there's not a hard and fast rule. And so that varies according to ICU, and we kind of decide, here, what is considered a spontaneous breathing trial. So, per the literature, pressure support should be between 5 and 8, okay? That's enough to overcome the resistance of the tube, okay? And PEEP anywhere from 0 to 5, okay? And so, personally, I usually do 8 and 5. I think maybe Dr. Jaggers does 5 and 0? 6, 0? 0. So it's still within this range, right?
Yes.
Okay. And so wherever you land there, that's okay. That's considered breathing trial. You keep them on the current FiO2 that they were on, so it's 50% or less, or they wouldn't have even met criteria for this. Duration, this is another place where there's a lot of variability. I tend to go about 45 minutes to an hour. Some people may prefer to go a full 2 hours. Per the literature, it's not recommended to go longer than 2 hours, okay? Unless you're doing more of a prolonged vent wean. Now, there's some circumstances which we're not really gonna get into today, where you have difficult patients to wean from the vent, and you might do pressure support trials during the day, AC at night. It's basically kind of working them, trying to strengthen respiratory muscles. But this is for like short-term vent wean, okay? So at least 30 minutes, no longer than 2 hours. And that's gonna vary according to the patient, okay? But I think as a hard and fast rule, I think after an hour, you probably need to, unless it's been specified to you otherwise, is it about an hour, I'd split the difference. Okay, does that make sense? As far as the numbers go? Okay. And that's from the latest guidelines in 2017 from the American College of Chest Physicians and the ATS. Again, this is the failure criteria, and just to reiterate, it's the breathing more than 35 times a minute for 5 minutes or longer. They're not breathing, so less than 8. Dropping their SATs, the symptoms of respiratory distress, accessory muscle use, the belly breathing, or the chest and the belly, abdominal paradox, they're diaphoretic, they look short of breath, mental status changes, and heart rate or heart rhythm issues. This goes again, if they fail SPT, you go back to the previous vent settings, and then you tell the RN, hey, that they failed, and you are going to be right there with them. You say, hey, University data. All right, so let's say if they passed it. So if passed the SBT, you could theoretically extubate the patient, right? Based on clinical findings alone. And y'all have seen cases where we've done that, right? You have somebody who's just an overdose, or maybe they were just left intubated overnight because they had a late surgery. They're otherwise fine and healthy. You put them on pressure support, they do great. Don't even need a gas, just pull the tube, all right? But all of these things are, there's no one thing that's gonna tell you who's gonna be successfully extubated. So it's kind of like everything else. The more tools that you have at your disposal to try to predict whether someone's gonna be successful, the better. And so that's where not only do you do the clinical findings at the bedside, them passing the SBT, but it's probably a good idea, and this has been looked at in studies, to combine that with ABG, the RSBI number, and the NIF, okay? And each one of those alone has been studied, but again, they're not predictive for everyone's. But if you put them all together, you got a pretty good idea. So ABG after the hour or two, RSV less than 105, that's been studied before, 78% positive predictive value for successful extubation if it's less than 105. A NIF of greater than minus 25 or more, I guess I should say less than, more negative than that. It's good, it's a good thing, they're strong, they can, okay, and y'all know all these numbers, I'm sure, but those are the things we're looking at. So when you do your SBT, they passed it, you grab your gas, you get your RSBI and your NIF, and then you would communicate that result to the pulmonologist, okay, and say, hey, here's what I got. What do you want us to do? Okay, and the whole idea would be hopefully to extubate these folks rather than at 5 p.m., maybe earlier in the day, getting this started. This would be a lot of nursing and respiratory driven, but in coordination with everybody taking care of it. Okay, we don't want you to pull the tube. It's like, oh, because wait a minute, they may have had something else going on, Maybe they still got pretty bad pulmonary edema, So that there are some things that still we have to factor in the clinical picture. Okay.
So if they fail, obviously, like you said, we're gonna interact with the nurse about it, but are we gonna put notes in just so y'all can peek in and look? Or are we gonna have like something else on our computer that's more of a check
I'm not
off,
well.
or-
So for us, the best way to see what's going on and communicate with everyone else in the team is a note. Just say, hey, failed SBT.
And
You
why?
want specifics as like
Well,
respiratory rate?
Yeah, breathe
Yeah.
40 times
Yeah.
a minute, tidal volume on 100 milliliters. SATs dropped to 70. Okay, I mean, it doesn't have to be a dissertation, but just a quick, hey, they failed.
This one.
Yeah. Otherwise, we don't really know, because it's really hard. Y'all's documentation, I know it does and same thing goes with the nurses. In Cerner, for whatever reason, it's kind of hidden, and and even if you find it, it's not like, it doesn't make much sense. But the little quick note is actually really helpful. Okay. Does that make sense?
Mhm.
Okay. Just extubation, just some random things in here, but most folks are gonna go to 6 liters. We can consider extubation to BiPAP or high flow cannula, and those folks who we think are maybe on, a little marginal, maybe higher risk for reintubation. There's actually good data to support, especially BiPAP and COPD and CHFers extubating directly to that to prevent readmission or reintubation. So always, and that's something you all, hey, if it's somebody that you're a little nervous about, well, they passed all their tests and did the numbers, but they're a bad COPD, you can maybe even ask, hey, what do you think about extubating the BiPAP? Just to be sure for an hour or two. while we transition to cannula. I mean, help us, y'all can use your clinical judgment too there, a little bit, and, at least maybe suggest it. Say, nah, don't worry about it, fine, but sometimes it's good to kind of bounce ideas off each other. Limitations, so we kind of hit on this earlier, but I always like to think about, well, what would keep us from doing this, right? And so that we can kind of be aware of those and maybe try to fight the culture and try to say, hey, we really need to start doing this, but because it's changed, right? It's different than what we've done before, so it's like, well, we've just not really done that. So but that's okay. If we're doing things that are evidence-based and that are recommended, then you're doing the right thing, right? It does require a little extra communication, which requires a little extra effort. It's kind of coordinating with nursing staff, coordinating with the docs. So that's just be aware that's an issue, and it requires more trust in you all, okay? And some of us docs are maybe a little hesitant to let you all make some of those decisions, but I think y'all are licensed, right? Y'all done this, and the way I look at it, it's letting you all use some of your skills that you have already to help us out. So it does require that trust, and we want to be doing the right thing by the patient, so we've got to have kind of a dialogue back and forth. I don't want people to be pushing the limits. Say, if they didn't pass the thing, don't do it. Don't feel like you gotta do something that if they don't pass the screen,
So
then
this is gonna be on all intubated patients?
well, that's the goal.
That's
the goal.
That's
That's the goal. Okay. So the way we've talked about this is I want to be the pilot, and to get everyone used to this, because it's hard to make big changes all at once. But if we can maybe start small and see how it goes, that way we can work through the kinks, because there's going to be maybe some issues that come up and you say, oh gosh, we should have done that a little bit differently. So what I'd like to do is at least start with my patients, and I think Dr. Jaggers and Dr. Basha have said they would want to participate as well. So for sure mine, and then I think we'll work in Jaggers and Basha as well, and then we'll kind of go from there. Okay.
So we just, I know y'all's favorites.
Yeah.
You're 85,
Yeah.
yours is this, Bosha's 85.
Yeah. Just do that.
So, yeah, that was gonna be my
That was
question.
it. That's
Just
it.
Gotcha.
Yep. Yep.
And work on the other.
Yeah.
I might suggest, cause I know like you've been here for a while and you know exactly what all the preferences are. But if we have a cheat sheet somewhere,
Yeah.
so if somebody who is normally in the ER is in the ICU, they don't have to question what does Dr. Rutledge want or what does Dr. Basha want, cause I know like Jaggers and Rutledge, their settings are a little different.
So me and Basha are 8 and 5, and Jaggers is 6 and 0.
Yeah,
Uh-huh.
Yeah.
but just to have that cheat sheet somewhere.
Yeah, that'd be helpful.
Maybe we could write it on the back of the things you were gonna get laminated.
We can do that, we can add it to it.
Perfect.
And like Markham's is not really in
Okay.
his is normally like 12 and 5.
Oh, interesting. Okay. Okay. Well, I think it's a good opportunity for us to do some things better for the patients, and hopefully kind of get this going.
And this may sound silly, but I know this is gonna come up. When it's your patient, but Dr. Markham's seeing them, do you want us to do it?
Yeah.
Or do you want us
Yeah.
not to?
It's good. Y'all are gonna hurt. I mean,
I know.
Yeah, we're
Yeah.
still getting
And
approval
you know
at the
that.
end too,
Not gonna hurt
like,
'em.
hey.
And it's all in a controlled environment.
Yeah.
It's
But we normally kind of try to make
sure, yeah.
our ideas his ideas.
Right, yeah.
If you know what I mean.
No, I understand. Yep. So, the ADF bundle, you guys are kind of intimately involved in part B, the SAT and SPT. You and the nurse has to communicate though, for it to work, or it will not work if y'all don't kind of get together when you're doing your rounds. And that's the kind of the biggest, I think, knowing the checklist, the screen, and whether they pass or not, that's good stuff, but unless you can coordinate with the nurse in the beginning, it's not gonna work. And then just communicate results. And let the family know, you know, what you're doing. Hey, we're gonna wake them up. They're usually pretty excited about that. Most families are like, oh, okay, yeah. You know, just let them know if you flip them, hey, we're gonna see what they can do this morning. They may or may not be ready, but we're gonna try. And they appreciate that usually. So. Cool.
Yeah.
All right. That's all I got.